Hello and welcome to the Chris Wolfe Podcast on iCode Media. Today I had a great conversation with Dr. Kevin Chan. We talked about myopia management in general. We discussed Treehouse Eyes, and really we talked about how do you incorporate the conversations that you need to have with pediatricians, family physicians, community health centers, other eye care providers related to explaining the importance of myopia management, explaining the services that you offer for myopia management. It was a great conversation. I really enjoyed talking to Dr. Chan. Please enjoy our conversation. And as always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. So today I want to talk about the MyDay multifocal for just a second. It has been a really great thing in our practice for our patients who are presbyopes of all areas, but those tricky presbyopes are always the ones that are kind of emerging, where they don't want to give up any of their far away vision, but they're having some struggles up close. And so what the MyDay multifocal has been able to do for us is to allow those patients to transition into a multifocal more easily. And then as we have those patients progress into other levels where they need more ad powers, it's been a nice smooth transition. So the ultimate hurdle that we've seen in our practice before the MyDay multifocal was that we'd have patients who would resist any transition to a multifocal lens because of that distance blur. We just haven't seen that. So if you haven't started using MyDay multifocal in your practice, I would encourage you to start, check it out, reach out to your Cooper reps for those trial lenses and commit to MyDay multifocal for your patients. I think they're going to like it. If you haven't checked out MacuHealth yet for your patients in Category 1 through Category 4, I think there's a lot of evidence that you should be considering. The first is, if we just look at AREDS 2 and what they talk about, MacuHealth is, so for patients in Category 3 and Category 4 AMD, MacuHealth is a great option for them that follows that entire protocol, and it also adds mesozeaxanthine to the mix, which, if you look at some of the evidence, I believe shows me that it's going to thicken the macular pigment better than without mesozeaxanthine. It also uses a correct AREDS 2 dose of zinc at 25 milligrams, and so you don't have to worry so much about the potential side effects of zinc. The other thing to think about, and it's beyond the scope of this, although you've probably heard me talk on other podcasts, is that in patients in Category 1 and 2, there may be some additional benefit to supplementing them with something that may be a little bit less than the AREDS 2, so you don't have to add as much to it. And that's where I use the MacuHealth LMZ3. And so I think if you haven't done this yet, I'd consider MacuHealth in your practice and for your patients. And it's been great for my patients, and we really feel like we have the ability to help those patients in all categories of macular degeneration. When we met the first time, one of the things that made me want to talk to you was, first, is I've seen you kind of around, the stuff that you've been doing with Treehouse Eyes and some of the things that you've been doing within myopia management. So it's always fun to kind of meet somebody in person that you admire from afar and see doing things from far away. And so thanks, first of all, for coming on the podcast. Second of all, I think it'd be interesting to kind of work through this evolution with you related to myopia management. Treehouse has gotten a lot of publicity. My sense is that now you're probably going to be humble about this, but my sense is that a lot of what has allowed them to do what they do is basically having a really great model physically that they can point to. And you're sort of the guy in that. Is that correct?
Yeah, so I've been fortunate enough to join the practice 6 years ago. And I was the founding optometrist for Treehouse Eyes. So at that time, I have zero patient base. So that pretty much, I start from ground up. I recruit patients from cold calling or distributing flyers to different schools and stuff like that. And that's how I get my feet solid in the practice. And but yeah, I've been giving so much opportunity and also work really hard to get the public awareness of myopia out to the parents. So they're getting more aware of this, and be more vigilant about what we can do to help their kids out.
So a lot of this becomes kind of this harder work that needs to be done. Most of us, and I'm included, so I've been in practice for 14 years, and when I got into practice, 2008 hit. We didn't take any managed vision care in the practice. My dad had dropped it probably 5 or 6 years prior. And, one of the mistakes he made was that he referred all those patients who had, instead of being like, well, we're an out-of-network provider, we're still on your medical plans, blah, 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 blah. One of the mistakes, and he would admit this, the mistakes that he made was he just sent them to other good providers in the area, especially with our Vision Source connections. He's like, look, this is a great doc. They're right down the street. They take your insurance. Go see them, they'll take care of them. And so take nothing away from them. They had to still build their practices. But by the time I came into practice, he wouldn't have been able to handle all those patients over that amount of time. But it was 2008, things had collapsed, and we needed a patient, an income flux or an influx of patients into the practice. And so most of us, we did what most people do, is you start accepting more managed vision care plans. And then there's this kind of life cycle that occurs where you look at your managed vision care plans, and I look at my schedule and my patient population, and most of my patients are no longer, they're being managed for other diseases. And so I've had these conversations with my associates, because probably the one pain point that almost every single practice has to go through is how do we attract new patients, and when they have medical conditions and they have a managed vision care plan, which is becoming more and more pernicious in the sense of, patients on Medicare with glaucoma have managed vision care. Well, when you accept that patient comes in, even if you've never provided managed vision, like comprehensive or routine services for them in the past, they now all of a sudden think they need to have this. And so I have these conversations with my associates by saying, okay, well, if we're going to move away from managed vision care plans, which would allow us to not have, even though we manage that kind of back and forth with the patient really well in the practice, we've got a good handle on it. The one source of conflict that usually occurs, if there is a source of conflict in the office, it is almost exclusively related to, well, this managed vision care plan, we wanted it this way and it was done this way, or I didn't understand that this was going to be covered. This is covered. Why isn't this other thing covered? And etc. So that becomes like this one barrier. It's always this constant theme, and across the country, that's kind of this constant theme for practices that they have to, if they can manage it well, which we have, they can overcome it. But I say to my associates, I say, look, if you guys want to go away from this, it's not going to hurt me, right? Probably not that much. My actual like professional income, it might hurt me a little bit as a business owner, but really, how are you going to get patients? Like, what are you going to do to get patients in the door? Because now all of a sudden, it's not like you get to sit back and wait for those patients to find you. You're going to have to do what Kevin Chan did, right? You're going to have to go kind of beat on doors. So I say all of that to say, is that an accurate assessment in your view about how the other ways you're going to have to market to the public? And if that's the case, then kind of walk me through that process for you and how you acquired, attracted new patients, really in a step-by-step way.
Yeah, so that's a really great question. I wish I could have $1 million answer for you. But I think I would just share my little experience about Treehouse Eyes. And as you probably know, but for some of those of you who are not fully aware of what Treehouse Eyes does, we are the referral-based myopia dedicated clinic, and we are based in Washington, D.C. area. And we are a really unique business model in a way that we actually don't take any insurance. Every patient I'm seeing, they're self-paid or through a flex spending account or health spending account using out-of-the-pocket money. And that is a really challenge for just like many of your practice. You're saying a lot of business financial challenges, especially during the financial crisis. Not every family can support or afford the treatment for myopia management. So we definitely have hit a lot of roadblock to see how we can open up more or try to overcome more barrier so that we can help benefit more families. So one of the big strategy we've been using is try doing word of mouth. As probably primary care is a great source of word of mouth. And if you treat one sibling, the younger sibling would probably follow suits. A parent would never follow. I mean, leave them aside and treat one kid but not the other. So you can definitely set up a good role model. Okay, when you treat one kid successfully, then they would, definitely bring the second kid or even third kid to bring your practice. So I have a lot of existing family who actually grow into multiple families just because of the word of mouth. And especially because of the uniqueness of a model, and we cannot really advertise, how many insurance panel we're in. In fact, it's going to be counterproductive. So we need to work harder to get the word out by outsourcing, some of the marketing tool to the public school, and also community health center. Let the word out so that parent will actually find you, just as you said. They will come find you based on your credential and your expertise. In fact, I'm very fortunate enough that I have seen growing number of patients who are actually not in my community. They're actually derived from different state or even fly out of state to come see us. So that's a really huge testimonial for us that we have been doing a really good job.
Yeah, I think to get a little bit more specific, because I think all that stuff is how it starts to travel and becomes a snowball, just like any practice that's doing those things well. It does become this snowball effect where, you have more patients than you can take care of, right? So that's a great thing to have happen. It does happen with many practices with sort of this traditional model. So give me an idea of when you're going to primary care doctors, you're talking primary eye care, pediatricians, and then to develop those relationships, give the listeners a sense of what you had to do to kind of open those doors at the beginning. Community health centers. I saw you did a TEDx talk. So kind of how do you open the doors for those things to start building those relationships?
I think for the arena of a myopia management, one of our biggest target is talking to pediatrician. Because they have the biggest source of patient base for you to, not to take the patient, but kind of share the patient care with them. And obviously, they are not too keen or too interested in, providing comprehensive vision care. All they do is just to provide vision screening, pass or fail. And at that time, when we first started, I actually knock door to door, to different pediatric office, to kind of introduce ourselves and let them understand what we can provide for them, and especially for our expertise in pediatric vision care. So that is how we can open the door and spark the conversation. Some of the pediatrician may not be too keen on getting into it just because of the insurance low reimbursement rate, but that is actually a really good source for you to tap into. Because if you said, you don't want to take that insurance patient because of the low reimbursement rate, maybe we can help you out. Let me take care of your patient, provide them, whatever they need for myopia, and then we'll send the patient back to you, CC to your primary eye care doctor. Then all three provider will actually, serve the best interest for your patient. We're not taking any financial interest for your patient, but we do actually can share some of the workload that you're struggling with. Because I know from my conversation with them, I think vision care or vision screening is by far the least favorite thing they want to do in the entire physical check. And so that is probably the first thing that we have tackled previously. And then the second thing is to talk about to different school, different community health center. And I know community health center is also a big challenge, mainly because the population is a little bit more moderate to low income, and not every family is inclined or receptive to paying out of pocket. All they ask you is always, does insurance pay for it? If no, then don't worry about it, forget about it. And so we did have those challenges at the beginning, but we keep being persistent, and we actually talked to some superintendent or healthcare administrator and let them understand the importance of myopia care for children. And in fact, a lot of children are suffering from learning, mainly because of vision problem, as you probably can echo to that. And so most of the time, they don't understand the health implication of why we care vision care so much. Mainly because they think that it's just one of the many sense that we care about. But vision by far is definitely one of the contributing factor for learning deficit. And last but not least, I also want to touch upon the big subject about how to get from clinical being a clinician to being a public speaker as a tech talk speaker. And that is a really good opportunity. And I'm very fortunate and honored to have that opportunity because without that stepping stone, I would not be able to reach out to those layperson, general public, talking to parents, talking to teachers, talking to nurses, because this is by far the one stepping stone for me to reach the audience all at once. And I imagine I can still recall the vivid memory that on that day about 3 years ago, I stepped on stage in front of over 1,000 people. That was before COVID, and people are so excited and ecstatic about healthcare because I was the only healthcare representative in the entire arena on that day. So I feel like I have been carrying a really a big burden for me to do a good job, to be the ambassador for eye care. So at that time, I really did something that I never imagined I've been doing in my life, and is to talk to thousands of people for something that I'm passionate about. And at the end of the section, I remember a parent who come to me almost bawling her eye out and saying that I wish I could have listened to your talk 20 years ago. I could have helped my daughter, all right, because she was already at -10 diopter. So that is a really heartwarming thing to hear. If you don't do our job, I think this is a miss opportunity not to do it well, as a primary care provider.
I think that's a challenge when you have patients, parents that sort of take this burden like, oh, it was their fault that they didn't do anything. How do you generally respond to that?
Obviously, you don't want to guilt them. You can only help them look forward. This is what we have today. And how we can help your kid is by looking forward. These are the available treatment modality that we can consider. Back in the old days, you and I may not have that opportunity, but now we're so fortunate enough to have this type of modality to provide to your children. So I think that is a optimism we can bring them. Obviously, we cannot look back and change the way myopia have developed. But the sooner we can disseminate this idea out, the better the results would be.
How do you respond to the pediatrician who already has an existing relationship with like a pediatric ophthalmologist who they send everything to, that is either skeptical of myopia management or hasn't ever heard of it before, or already doesn't want to break the relationship because they just assume that the pediatrician that they're the pediatric ophthalmologist that they're going to send those patients to is going to treat those patients if it's appropriate? How do you respond to that?
That is another status quo that we tried to overcome when we first started, because we already are aware that pediatric ophthalmologist is the first source for the pediatrician. But it's actually a good opportunity for us as optometrists to work alongside with the ophthalmologist. And most of the time they would say, oh, your kid is too young or just not ready enough for contact lenses or orthokeratology. But that is actually the door for us to introduce them. Okay, there's actually other viable opportunity for your patient. In addition to patient prescribing atropine, that's great, but some patient may need to have more than just one treatment alone. So we provide us as the source for providing them contact lens option. If the patient do need that service, okay, we're here to help your patient out. So we're not taking patient away from the ophthalmologist, but also at the same time, we can share the care mutually.
I want to read this to you. I'm pulling it up right now. Hopefully it will come up. But essentially, one of the things that I thought was really interesting about the position that the American Academy of Ophthalmology has taken on myopia management when I read this was essentially that the risks and benefits of orthokeratology don't outweigh the risks of orthokeratology don't outweigh. There's more cost-effective options, and so so they've sort of softened that a little bit, but they kind of put this. There's a risk of infection with ortho-K lenses. This is exactly what they say. Quote, there is a risk of infection with ortho-K lenses. They are also more difficult to fit compared to regular contact lenses, and more follow-up visits to the doctor is needed. That's how they end their kind of assessment of orthokeratology within myopia management. And this was November. This was actually 3 days ago. There was another physician patient that they talk about the fact that it's not a cost-effective option. How do you respond to that?
That's an interesting question. Not a cost-effective treatment. What do they mean by that?
I'm not sure. I think, I'm a little jaded. I guess I can't find that statement right off the top of my head here, but the statement of kind of this is what I want you to respond to mainly is there is, after we talk about ortho-K lenses, there's a risk of infection with ortho-K lenses. How would you respond to that?
So I would tell my patient that, risk of eye infection is definitely present for every type of contact lens modality, including ortho-K. And but studies have found that the risk of having microbial keratitis or any other eye infection is very negligible as long as you take good care of the lenses, maintain good hygiene. And that's what I've been telling and sharing the knowledge with the ophthalmologists. Many of them actually are surprisingly quite receptive. When you do a one-on-one conversation, especially the young MD, they're actually quite embracing myopia management as part of the arsenal.
Yeah, I mean, I would expect that as well. I think my reaction to it is, well, yes, contact lenses have risks, medications have risks, surgeries have risks. It seems still like they're trying to kind of stay away from, like trying to advise people away from it. Although they're kind of begrudging this a little bit more. It's kind of interesting to see over the last couple of years how they've seemingly slightly warmed to the idea, but they kind of minimize some of the risks of the other options. That's the only thing I thought was striking within those kind of comments. And I'm trying to find the other one related to cost-effective options. But when I first read that, it was what was striking to me in terms of cost-effective options was you could take out orthokeratology and insert LASIK, and their story wouldn't change. Basically, what they were saying is glasses would be a more cost-effective option for patients to correct their nearsightedness, and orthokeratology has all these other risks, so it's probably not worth doing. And then if you could just insert, right, myopia can be managed with glasses, and LASIK, it has all these other potential side effects, so you should just stay with glasses, right? Like they would have never made that same comment from a surgical standpoint. And I think it was just interesting, right? That's I don't know. It's neither here nor there, but it's an interesting thing if they're taking a position like that. It's just important to know how would we respond to that position, especially if that's their organization.
Yeah, I also find it interesting that, on a good side, they soften up the stance about myopia management is not harmful, not detrimental. But at the same time, I found that one of the strategies I've been doing with ophthalmology, especially for those patients sent from the MD office, I will actually send them an annual report, back to them, even though they may not be the one who referred the patient out. And I want to make a statement that, your patient is doing really well with ortho-K. So kind of negate the fact that what you're saying is probably untrue. And there's a lot of robust evidence and data out there suggesting that ortho-K is by far one of the most effective modality for myopia management. So they're missing the huge opportunity, if they want to truly help the patient for myopia.
When we met at AAOMC, I was like, I rarely in our profession feel like a fish out of water. I've been doing myopia management in our practice for basically since I've been, actually I would say I've been doing orthokeratology in our practice, and probably some myopia management unintentionally for the first 3 to 4 years of, doing orthokeratology. But then as soon as we sort of start seeing some of the evidence come out, really kind of good evidence with orthokeratology in the early tens, late zeros or knots, and then early tens. We're kind of doing it more purposefully, and so I say all that to say that I still felt like a fish out of water. Like when I was at AOMC, they are. I rarely go into a situation where I don't know a significant number of people, and the only person really pretty much that I knew at that conference was Cheryl Chapman, who's also a partner of mine in Peak. And then we've got a long-standing kind of history within the profession. And so she's been awesome. She's a wonk on a lot of this stuff. And she was good to kind of introduce me to a few other people, but it felt just totally weird to me. And so one of the things I thought about was, all right, well, first, how many kind of general primary care optometrists are out there that would feel the same way in a conference like that? It wasn't that people weren't welcoming. It's just, it wasn't my normal crowd. And then second, what is your perception on how many of us are managing myopia, like in terms of the population, like really managing it right within their practice? What's your sense right now of optometrists, primary care optometrists managing myopia beyond just the spectacle correction of refractive error or contact lens correction of refractive error?
Yeah, so I think I read a study a while ago saying that they found 80% of those respondents who are mostly primary care eye provider, and 80% of them said they believe and understand the importance of myopia management, and they also prescribe ortho-K. But I think less than 40% of them actually actively manage myopia using all those modalities that they talk about. So that's a huge knowledge gap and discrepancy of what the beliefs are versus what the actions actually tells. So obviously, you and I know there's still a lot more work need to be done to spread the word out, let alone it's not just about public awareness of myopia management. It's how to convince our colleagues, our peers to be on the same ground, okay? Because as far as we know, Canada is one of the first country that fully recognize myopia management as the standard of care, and this is something we truly need to work on as a profession. Otherwise we'll be all over the places. Many patients coming into my office and saying, "Oh, Dr. X, Y, and Z says so and so," and they have no idea how to, make it make sense to them, because every single doctor said different things. And we as a profession, if we cannot be seen on the same ground, and it's just hard for us to make it a better place. So going back to the question about, I do agree, when I first joined AAOMC, it could be very daunting, could be very overwhelming. And I didn't know anyone, and I was sitting in the corner, and I just want to listen, to what they say. And but I think AOMC is still kind of hidden in the gem, and not a lot of people know about the organization and what it does. So I think using this type of platform and sharing the knowledge of AOMC is a great thing for ECP to understand there's a lot more out there, just the primary eye care. And I'm sure many of you have participated in different lecture, workshop in dry eye, glaucoma, or refractive surgery, but many of them does not include myopia management. Many ECP is still hesitant to jump into the pool of treating children.
Why do you think that is
a quick challenge, mainly because most of the time they thought it could be very time consuming and not cost effective, or simply they don't have enough resources for dealing with pediatric care. But in fact, in my day-to-day practice, I only see kids day in and day out, even though I would say it's quite exhausting at times. But, you actually make a huge difference for those young kids because they are looking up to you 10 years later. Oh, Dr. So-and-so, Dr. Wolfe, Dr. Chen have saw me 10 years ago, fixed my myopia. Now I'm still at the same prescription. So it's a really huge rewarding testimonial for us to see.
One of the challenging things with patients is when they invest in a really high quality pair of glasses and customized lenses, it can be challenging to keep those lenses clean, keep them scratch-free, smudge-free. And so we now have the ability with Crizal Sapphire HR lenses to offer our patients the best-in-class anti-reflective coating in a way that is really high resistance so that they're not having to care for their lenses as much as when those lenses are caring for them. So remember that you can provide patients that best-in-quality, best-in-class transparency, clarity, durability, and UV protection in a single Crizal coating. If you want to learn more about Crizal Sapphire HR, contact your Essilor account executive or visit essilorpro.com/Crizal. I get questions all the time about how do we use 9.2 codes and 9.9 codes and which ICD codes go with different CPT codes and what can be billed together and what can't. And this confusion, this uncertainty really holds us back oftentimes to be able to do what we want to do, which is help our patients see clearly and provide their best opportunity for a lifelong vision. And so we built iCode Education for that specific purpose. We have lots of resources that are based in helping you understand disease states, helping you understand revenue cycles and billing and coding practices. So check out eyecodeeducation.com. That's EYECODE education.com. And we have a specific bundle there for you if you'd like to take advantage of it. It's the Premier Billing and Coding Bundle. We've got a 10% discount code just for listeners of this show. You can just, in the coupon code at checkout, you can enter in iCode Media 22. That's EYECODE MEDIA 22 at checkout. We'd love to have you. We'd love to work with you. Check out iCodeeducation.com. Why is myopia management important? I think I'm going to ask you that question. I'm going to preface it by saying if we survey primary eye care providers and they say that 80% of them say that myopia management is important, but 40% of them actually do something about it, there's probably got to be this disconnect between yeah, it's important, but I don't have this really burning deep drive to say zero myopia progression is what's acceptable, or at least half, right? I'm going to accept nothing less than half or 60% or something. Where does the complete kind of embracement of the importance of myopia management come from your perspective? And how can you communicate that to other doctors who are kind of yeah, it's important, but look, a -4 is not that much worse than a -3 or a -2. It's not that much worse, right? How do you communicate that to people, and how do you start kind of owning that as no, there is, any progression is too much progression, or whatever?
Yeah, so definitely a broad question, and I think the way I usually address this is by sharing the analogy of when you treat glaucoma. You have a patient with IOP, early to mid-20s, or having a suspicious cupping. Why do you consider it important? I will throw that question back to them. Okay, why do you think it's important to treat that glaucoma suspect? It's going to take you a lot of chair time and follow-up visit to do visual field and other ancillary testing. And they said, oh, it's because we want to prevent vision loss. I think that echoes them right away. Light bulb. Myopia management is important, mainly because we want to prevent any type of ocular manifestation of retinal detachment, glaucoma, and cataract. It's just not about seeing. Vision is about how to manage the lifestyle. And as you probably heard about, myopia management is not just about the clinical modality. It's all about managing the lifestyle, behavioral changes. All these things come into play. We are doing this as a holistic approach. And so try to not to fixate on just which modality work best or which type of biometry work best. It's just part of the equation to make it possible. And so obviously there's a lot of ECPs still are a little hesitant about, getting into the field or simply feel overwhelmed when we get to that type of big conference. I feel that and I also experience that. But I think the first thing we want to do as a profession is really just, plant a seed out. Okay, you really need to talk to your patient about this idea. All right. And if you don't really mention that, no one would know. And by the time they find out about it through Google, and it's probably you're not doing your good job to provide the best care for your patient. That's my personal opinion.
Then is zero progression, is that a achievable standard in the majority of patients?
Well, we expect young kids definitely grow based on the development stage, and we don't expect zero growth. In fact, it is not really realistic and not attainable. Majority of our patients typically would slow down, or at least having a reduction of myopia progression by nearly 75% when they first start treatment. We actually done a 3-year retrospective study looking into all these sorts of clinical efficacy and see, how far we can go. Obviously, we cannot achieve 100% reduction rate, but 75% or higher is actually a really decent number. And we typically expect, based on the ametropic growth, we'll expect the kid to grow about 0.1 to 0.15 millimeter per year, even without any type of treatment. So that's considered normal. And what we try to achieve is not to reverse the progress. All right, we just want to slow it down, mitigating the growth over time. And so that is something that is definitely attainable if we can do something out at least the very minimum.
And so then what you would say then is an annual progression of, so you would be happy with maintaining this simple, this straightforward, like the existing treatment plan. If a patient was progressing at a rate of anywhere between 0.75 and 0.05 and 0.0, wait, you said the normal progression rate was how many millimeters? 0.1. Yeah, so you'd be accepting of 0.5, 0.05 or 0.075. And that amount of progression in your mind would say, look, this is basically half. Or if you can push it further than that, you're saying, okay, 75%. So maybe we cut out another quarter off of that. So I don't know, 0.05 to 0.03 or something like that. That would be kind of acceptable to you.
That is considered pretty a successful case.
Yeah.
Yeah.
Mm-hmm. Yeah. And you wouldn't necessarily say, boy, we got to do another thing, right? They're coming in orthokeratology. You've got that stability or relative stability or progression, minimal progression. You wouldn't say, well, now we got to change your optic zone in your orthokeratology, or we've got to change, or maybe treatment zone is the better word, or we've got to add atropine or whatever. You wouldn't necessarily push on that because you're not having the perspective of we can't progress at all.
That's correct. That's what would be my approach. And we typically don't want to initiate combined treatment at the beginning unless patient is already at high risk and based on the risk profile. And but majority of our patients typically would do well even with just ortho-K or soft lenses.
Yeah, that's been my experience as well. And I always laugh when I see a study that was done by one doctor in one clinic that says, their success rate was 100%, but it is weird because when I talk to other providers, they kind of have this same thought is like a lot of the studies will show from an orthokeratology standpoint, depending on the study, and there's some other nuances there, but 40% reduction to 80% reduction. There's kind of this wide swath of different impacts. And I know you can look at a lot of different variables within those studies, but I find that, most of my orthokeratology patients are pretty darn stable. And when I talk to other orthokeratologists, they say the same thing. They say that most of their patients with just a single treatment like that are more stable than what they would expect based on the preponderance of those studies. What are your thoughts about that?
Yeah, so I think having mono treatment is obviously better than nothing, better than single vision spectacles. And many patients are just not aware of ortho-K and soft multifocal lenses. And whenever they heard about something, oh, contact lens touching my eye, oh, it's not going to be worth working for your kid. But I can reassure them that, this is something better than what you expected. Kids are actually surprisingly doing better than adult and teenager. And contact lens is definitely one of the greatest modality for treating children.
So, Dr. Chan, let me kind of give you one last thought. Like, if you had parting words for the audience about myopia management and kind of the incorporation of that at any higher level than what you're doing right now, what do you say to them?
Yeah, I think as a primary eye care provider, and we have obligation to make the best out of myopia care, because what we're doing right now, and it's just not enough. Not saying we're doing it wrong, but I think we've been doing it for the past 700 years, prescribing single vision glasses, historically, and it's just not meeting the cut anymore. Because especially if the technology is getting better and better, we are advancing, but we're still prescribing the same old modality 700 years ago. We're not doing the best interest for your patient. And even if you have a lot of thought, hesitation in your mind saying, we don't have resources to buy this equipment, or I don't have enough staff or enough time allocated to myopia management, I think all these things can be sorted out as long as your mind is set into myopia management. And again, not every ECP needs to dedicate a practice solely in myopia management. That's not my goal. My goal is to hopefully plant the seed into every doctor's mind that myopia management is one of the things that could be the most rewarding, if not the most, could be one of the most rewarding things that you can do in eye care, because you're changing someone's trajectory to better vision for life.
Awesome. And then people want to reach out to you, have questions, want to book you to come talk. How do they find you?
Sure. So you can definitely email me, kevin.chen@treehouseeyes.com. We'll be happy to address any questions, or feel free to come in for a visit. I'll be happy to share with you about what we do in Treehouse Eyes.
Awesome. Well, Dr. Chan, thanks so much for doing this. It was fun to meet you in person. It's fun to do this again virtually, and I hope to see you soon at another meeting. And again, appreciate it.
Thank you, Dr. Wolfe. Thank you for having me today. Appreciate it.